Time everyone. Today we will discuss regarding techniques of mini gastric bypass. I am a student of bariatric surgery with respect to all seniors. Just this is my opinion. In my little experience in mini gastric bypass, the position and trocars and how can we do mini gastric bypass, it is only my opinion and again our respects to all my seniors, especially uh, those are pioneer of mini gastric bypass and one of the most respectable and most respectful sir, Professor Outledge, really is doing his best, and as well as Professor Carbajo from Spain. So really they are doing their best regarding mini gastric bypass and have lot of experience. In my opinion, supposition is V-shape, patient is in supine position and semi-lithotomy. And our first occur in male position in male patients 10 centimeter to xiphoid process, that is 10 millimeter optical port just lateral to midline, left side of the patient, just lateral, just touching the linea alba. In female patient 12 to 15 centimeter from xiphoid process. Our second trocar is also 12 millimeter, and that will be and this is very important. So when we put our first trocar, that is 10 millimeter optical, after inflation of abdomen, so position of patient, this is very important. So our bed must be 45 degree, not patient. Patient not in sitting position, bed must be like this 45 degree, and patient is, because patient is fixed with bed, there is no problem. And then we can put our second trocar, and our second trocar, this is just lateral to first trocar, 10 centimeter lateral to first trocar when patient is in position, patient is in bed is 45 degree, this is important. And for 10 centimeter lateral to first trocar, and this will be 10 centimeter lateral, I mean left side of the patient. So our third trocar will be also 12 millimeter, and this will be 10 centimeter from first trocar, but lateral upper side, lateral to falciform ligament, not parallel to first trocar. These are main points. So it will be superior lateral to first trocar, but right side of the patient 10 centimeter from first trocar, about mid of, if you can imagine, mid of the xiphoid and first trocar, but lateral side, I mean right side of the lateral to falciform ligament, this is one. Third one is 5 millimeter in epigastric ring, and fourth one is also 5 millimeter, and that will be anterior left side of anterior axillary line and 2 centimeter just below our ribs. So after some of my colleagues also asked me regarding his angle dissection. So his angle dissection, I think, especially for newcomers, especially for those who have just or are doing to start, you're going to start mini gastric bypass. So it's very important, because when you do dissection in his angle, so your last stapler you can staple easily. So you can start stapling, and our first stapler is with the hand of surgeon, left hand of surgeon, from trocar, that is right side of the patient. So these are points. So before this stapling, so we need space. How can we put stapler, how can we staple the patient? So dissection of incisor angularis, if we can also discuss like steps. So first step was in intra-abdominal, first step was dissection of his angle. So second step, when you are doing second step, so second step is just dissection of incisor angularis. So there is no need to dissection much more, no need to devascularization of the stomach. Just 2 bites, really, this is my experience, just with 2 bites of harmonic or just 2 bites of LigaSure, you have access to, if there is no adhesion, you can have access to in lesser side, posterior side of the stomach with meticulous dissection. At the same time, when you are grasping the gastrohepatic ligament near just the angle, that's the angle of angularis, Incisor angularis, just you, these are points you also see in my video. So you can grasp this gastrohepatic ligament upside and your assistant. So this retraction is very important. Grasp the stomach and retract this retract the stomach. So below and lateral. This is attraction. So then you can do easily cut the dissect the gastrohepatic ligament just touching the stomach wall. So then we will you can easily access to lesser sac, and our first stapler is also with the left hand of the surgeon from third trocar, that was just right side of the falciparum ligament. And again everything is very important. So when you are doing stapling and your first stapler, so your first stapler must be horizontal to stomach. And again you must confirm there is no NG tube, there is no OG tube in the stomach when you are going to staple, and you just staple transversely. And when you grasp the stomach, just see this, and again this stapler is 45 millimeter, 4.5 centimeter. And again, which type of stapler, so it depends on the patient. If male, so you can use green, you can use gold, you can use tri-stapler, it depends on the stapler. An important point, you must confirm there this stapler don't cut completely, and 45 millimeter don't cut completely. And again, when stapler is in your left hand, and with right hand you must grasp stomach ball just near to stapler and retract upside. So with this maneuver, so the length of you can achieve maximum length of your pouch, because in many gastric bypass the milestone, the basic thing is length of gastric pouch. So this is first stapler, and then you with the help of your assistant you have easily access to posterior side of the stomach, and you must additional lysis, you must care to splenic artery, must care to pancreas, must care to short gastric, and then dissect. And about three, we need 360 millimeter staplers. Again, it depends on the patient gastric pulp, so blue or golden or tri-stapler, it depends on the patient, male or female, and like this. But the something that was again important. So when you do first, our first stapler was transverse, second is just vertical. But when you put your stapler and grasp this gastric wall, then ask to your anesthesia colleague to put Sizer, OG tube, or any name you want to. So that must be 38 French F. So you can put your, you must put your Sizer inside the stomach, and you just no, not permission, don't maneuver anything. This Sizer will come in side of so lesser curvature and exact the place you want. There is no problem. It may be, it depends on your anesthesia and your colleagues and assistants. So when you put your Sizer, then you can grasp stapler and you see, and just touching the, just kissing the this Sizer, you staple. And so like this 3 or 4, more routinely 3 step, we need 3 stapler 60 millimeter. And when because we also dissect angle of it, so your last stapler will be easy, and like this you make a best gastric pouch that is ready. So now regarding intestine, so again this is very important. So there is no problem, don't worry regarding this, just momentum. You can also manipulate the momentum medial superior side. Grasp, these are grasper are traumatic, just grasp the momentum medial superior. So medial, and your cameraman exact is seeing the left upper quadrant. So this is very important. And your also assistant also help you, and then you can mention the ligament traits, and then you count on, again it depends on length of BMI, and you need 150, 160, 180. Routinely I use above 40, 180 centimeter. and then mention the place. And again, anti-mesenteric side, you perforate the intestine, small intestine. You can perforate with monopolar, you can perforate with harmonic, fixed arm. So when perforate, so again it need dilation, little dilation. You can dilate with your single action uh, grasper. And again, for before this, we must also ready the gastric pouch before this process. We must also perforate uh, uh, gastric pouch. So routinely the best is side to side. When we do side to side anastomosis, it's very good, and also anti-reflex, and so many of big names, many of professors so also recommend this anastomosis side to side. So if you cannot do side to side, best is side to side. And again, so posterior side is again best, because due to gravity and all these things, posterior side, posterior anastomosis is best. If there is some adhesion and you cannot do, and there is more uh, vasculature and like these things, so we can also do anterior side of, we can also use the anterior side of the gastric pouch, and we can do anastomosis here. And so be careful when you are manipulating the intestine. The blunt side of stapler must put inside the intestine, and don't retract much more up, because your gastric pouch is much long, and you can easily retract your gastric pouch toward your intestine, and can easily grasping. And again, another point, when you are stapling and you're doing gastrojejunostomy, at the that time also grasp the gastric pouch with your left hand, and don't free this, because it retract little more upward, and then so create problem for you. And same time, when you are stapling, must grasp the gastric pouch, and then when it will be finished, okay, then don't open your stapler handle, because it will again create problem, because after that, when just in the closing, when you are coming out from the your gastric pouch, so your stapler must be in closing shape. And again, you can use also, there are many methods to close this defect, and I prefer so PDS 20 with PDS 20 and swimming, and in mostly in one layer, and some cases I prefer in two layer. And at the end, you can check the air leak with air leak. I routinely check with air leak. And it will be finished. And also after this, so hemostasis, this is very important. You must check, and your assistant must detect the gastric remnant upward, and you can see the gastric, the stapler line, because the most common place of bleeding in bariatric surgery is stapler line. You must check, and you can irrigate, and you can also check the short gastric region. And then, so I prefer, routinely I prefer drain and corrugate drain inside at least for 3 days. So this is a very short, and again, there is many questions in my discussion. And again, with at the last, so again, I respect to all my seniors, and I need your guidance if any question. So I will be available. Thanks again.